look at yeah, lovely, thank you. Today's agenda. So this was obviously published for you all. We've got the next 2 hours together. The chat function is enabled, so it's lovely to hear from you. So please do be popping comments in there and questions as well. But there's obviously the opportunity to ask questions at the end of each speaker's slot, and then obviously we've got the Q&A session at the end that you can see as well if you're able to stay for the full meeting. We will publish the Q&A document as usual alongside the slide packs and the link to the recording, so that you've just got that synopsis again to look back on at some of the responses from the key speakers that are with us today. So just gentle reminder to remain on mute unless you're speaking, please. And I think we'll start with the officers update, then obviously HQIP will follow on from Marina and I. We've got LEDAR joining us, and then a nice update as well from Chris O'Connell. So if we just move to the next slide, please, Marina. I think we're just sharing with you again some of the health and wellbeing resources and links for you all, just so that you're looking after your own health and wellbeing and that of your teams as well. So it's worth exploring, and the toolkit is really good, both for you as an individual, but also if you're managing teams as well, and obviously for us supporting our colleagues and up the tree as well. Can't emphasize enough that the importance of us looking after ourselves and each other, in terms of the fact that then we're in our best possible state to be delivering safe and effective care to others. So yeah, do have a look at those links that we've shared for you. So if we move on to the next slide, then I think it should be our officers update. Yes, it is. Lovely. So we can do a quick scoot to the next one, I think, then. Marina, lovely. So key points really for Chair's update today. Just to add at this point that our slides are often quite full, but it's because they can also act as that standalone information source for you on the forum and the website as well, so that you can go back to it to revisit some of that information, and obviously that recording that's available as well. So the forum that we're referring to is the NQICAN Network and Sharing Forum. We'll pop the link in the chat. Please do head over and join if you're not yet a member. It's a fantastic platform and a resource that allows our clinical audit community to link in and network, share and learn together. So it's worth joining. We have experienced a few technical issues with the forum over the last few weeks, but it is now officially back up and running, and we do apologise. Our technical partners have been working hard behind the scenes to really understand what went wrong and putting the fixes and the patches in to get it up and running for us. So it's back up. Please do go back to the site and carry on networking. So these are the key points that we're covering today. So I think we'll move on to the next slide, please. Marina, it is only 7 weeks since we last met, because as you remember, we rescheduled the September meeting due to some of the strikes that were going on around the country. So in the last 7 weeks, I think a lot of our focus and resource really has been supporting our regional network chairs, and currently our networks that don't have a chair in place, where we're running the expressions of interest process for those areas. We have met with HQIP. We've held our regular steering group meetings as well to try and keep progressing those improvement priorities that we are taking forward through both Marina's and my roles and our co-opted members and the task and finish groups. We've finalised the bi-ennial annual report 21-23, which we'll touch on a little bit later as well. And on behalf of NQICAN, we've continued to support the NHS Futures platform, that taking action on national clinical audits. So again, if you've not yet registered for that workspace, we'll pop the link into the chat for you so that you can then register your interest to join. We can activate your request, and we can all start to begin to build that content there on that platform for us all to actually be working together to take action on all of those national clinical audits that we've all got on our high priority programmes. Obviously, all of our activity that's undertaken in NQICAN by the core members is obviously driving forward that forward plan as well. So if we move to the next slide, we can officially announce that we've published our bi-ennial annual report this morning, so it is now available on our website. So please do head over. We'll pop the links for the website in the chat as well for you, and we'll also make sure that we put the direct links onto the forum so that you can link to it from there as well. Please do go and take a look at it. It showcases our achievements over the last 2 years, and these are our achievements as every one of you's contributed along the way. So it's our clinical auditor community that have really moved things forward, I think, as a collective. So I think there's about 30 pages to it. It's quite a big report because it does cover 2 years. We do want to continue to hear from you in shaping our priorities going forwards, though. I think in the last 2 weeks, as we've said, we've experienced some technical issues on the forum. Otherwise, I think we would have heard back from you all in terms of where you think we need to take the direction for the next 2 years. We know that we will be continuing with, I think, 4 main priorities that we've got at the moment, which is taking action on the National Clinical Audit, our bringing innovation into our clinical audit community more through that series of webinars with the Health Innovation Networks, and being led by Sarah Chesel, one of our co-opted members, who's the head of the Innovation Hub, the Dorset Innovation Hub, and looking at implementing those medtechs and then measuring that impact through clinical audit. Kerry's obviously leading on our measuring success in our local programmes improvement priority as well, and we feel that that's something that we need to keep pushing, so that we're all sharing the tools of how we actually do that, so that we can take those back to our own organisations. And Marina's leading on obviously updating that education and training directory. So there's quite a bit there. We're obviously wanting to put on a lot more events for you over the next 2 years as well, and we're hoping that you're going to come forward with some topics so we can put on those national events for you. But obviously we do want to hear from you, because if you feel that we should be taking things in a different direction, or there's particular topics you want us to focus on, then please do feedback to us, and we will feed it into our improvement priorities as we go forward. So if we can move to the next slide, it's an opportunity really just to plug the expression of interest process as it's currently out for our communications lead for NQICAN. It closes on close of play Thursday 14th of December. Now you might be interested in this role yourself, or you actually might know of someone that you think would actually be good for the role, so please do let them know, give them a nudge. You do need your line manager's support to be able to undertake the role, but there is the ability to claim for up to 2 days per month for reimbursements of time back to your employing organisation. And the role really does encompass supporting our members through the forum, managing that NQICAN inbox where we get a lot of emails coming in with lots of requests and sharing of information, creating those newsletters that you get every month from the forum and quarterly from NQICAN, and trying to share more widely those discussion threads and tools and that networking that's going on the various platforms that we host. And obviously supporting both Marina and I with running the national meetings and supporting the regional chairs within their roles as well. So it is quite an exciting role to do. If the 14th of December is too close a deadline for you to get your line manager's support, but you're really interested, drop us a line, submit that EOI, and just let us know if it's going to take a little bit longer to get that evidence of your line manager and your organisation support to do that role, because we don't want to miss any good EOIs that might be coming in. So yeah, please do have a look at it. It's been circulated, it's on the forum, and we can resend it out again. So if we move to the next slide, then I think yeah, it's just a chance to touch now on the regional networks as well. And we've got a group of really dedicated individuals who are currently leading the regional networks as chairs. We know there are a number that have deputy chairs in role, and we've got another network that's got a steering group to support as well. Now these individuals really are dedicated to the cause, but they can't do this alone. So we're really calling for a bit more support from our network members if possible, please. So you can get more involved in a number of different ways. So it might be that you volunteer to join a steering group who will support the chair in agreeing the agendas, inviting speakers, taking the meeting notes and managing those action logs. Or it might be that you feel that you could take on that role of deputy chair and really have a go, and maybe you want to step up to that chair role in the future. So you want to dip your toes in and see what it's like to take part in a leadership role of that regional network. It might be that actually you've got some comms experience, and it might be that you could provide those skills to the role of leading the network. It might be that you're techie. It might be that actually you could help run the technical side behind the regional network meetings to support the chair, to make the meetings a bit more interactive with running polls and having breakout rooms, etc. So it's just trying to think about what you could potentially offer to help to the chairs to run these networks as we move forward. And I know some regional network chairs at the moment are considering maybe having a bit of a rolling programme of offering individuals the opportunity to maybe have a go at chairing a meeting or to get involved maybe on a rolling programme aspect as well. So lots of opportunities coming up. If you're really interested in helping your chairs, please do get in contact with them, because they really would value some more support as we move forward. We are currently out for expressions of interest for the chair role for the East of England Clinical Audit and NICE Network, the Greater Manchester Clinical Audit Network, and we're currently looking at the EOI process in Swans, the South West Regional Network as well. And just to remind you, we'll pop the NQICAN email address into the chat for you all as well, should you not be a member of your regional network and you want us to put you in contact with your local chair. So if we move to the next slide before I hand over to yourself, Marina, to give us an update on your role. It was, again, just to provide that opportunity to just quickly touch on purpose of the open meeting and the purpose of your local regional meetings, really. Open meeting as we're here now, providing that open platform to hear directly from our stakeholders and other representatives of our clinical effectiveness work streams, with that two-way communication of being able to ask questions and clarify the information that we're then going to take away and take forward in our own organisations, but also that of our partners across our systems. The regional network meetings offer that more local discussion about how we're all taking these initiatives forward, our successes, our challenges, sharing and supporting one another, but also looking at how we can actually make those improvements across our patient pathways. So that's hopefully clarified it slightly for you all in terms of the difference between the two meetings. But our regional network meetings, they do rely on our networks in terms of the success and the outputs, and obviously that member participation as well. They are network meetings, should be interactive, lots of discussion, sharing and learning. So maybe if you can't attend, you send in somebody from your own team so that your organisation's got a seat at that table at that regional network meeting. So next slide then, please, Marina. I think it might be my last slide before I hand over. And it was really just to highlight, and I know HQIP are talking to you shortly. They will talk to you about their publication, but there was one particular article in here that I wanted to highlight to you really as part of our officers update, and it was an article by Jill Stoddart, who's the Director of Operations for the NQICAN programme. And it's quite timely because I know we're all about to go into Q4 and our own organisations will be looking at our business planning for the next year. We'll be setting our business objectives for our teams for 24-25. And in Jill's article, she's really starting to challenge us on where our organisations are really in using our data. And it's a lovely table. It's got 3 different columns in it for where you could undertake a self-assessment against about 8 different metrics and work out where you are as an organisation. And it almost then sets you that vision of where you should be aiming to. So I know Marina and I are going to have a look at this. We're going to have a look at the table and maybe start some threads on the forum. And it might be that as we move into the new year and into spring that we do put on a Teams event where actually we can all come together and start to look at how we can then use data a bit more effectively within our clinical effectiveness work streams in our own organisations. So I thought if you don't take anything else away from today's meeting, maybe take that one thing out of today and read the cornerstone, the QI publication and Jill's article really, and look to watch this space, I think, and Marina and I will be in touch again and start some threads on the forum about really looking to see where we can take effectively utilising our data, our national clinical audit data, from participating particularly in NACPOP and the other quality accounts topics, but also triangulating it with our wider clinical effectiveness information within our organisations and across our systems. So I'm not going to say any more there on that one, Marina, and I'll hand over to you now to give us an update on your General Secretary role.
Hi everyone. So for those who don't know me, I'm Marina Otley and my role with NQICAN is that of General Secretary. So that involves looking after things like reimbursements, governance arrangements, and alongside Vicky also acting as Deputy Chair to do things like supporting networks and all those sorts of things. And today, apologies, today I am also trying to run the communication side of things, so letting people into the forum and running the slides. So if I look a bit all over the place, then that's why. Hence why we really do need somebody to come forward for that comms lead. So just in terms of my role then, so the first thing just to discuss is around our reimbursements. So for those who aren't aware, NQICAN is able to we are able to claim reimbursements of time for helping to run our obviously our network as NQICAN, and also helping to support those regional networks. Our reimbursements claimed so far for 23-24 is just under 12,500, and we're forecasting to come in at just under 28,000 by the financial year end. And as Vicky's mentioned, we are already, as you already do, planning for 2024-25 already. It's surprising how quick the time goes. Another part of my role is around managing those declarations of interest to make sure that obviously all of our networks and those involved in terms of running our regional and NQICAN networks are declaring any interests on a quarterly basis. And I'm pleased to say those were all completed for quarter 2, and there were no conflicts of interest, and there was also no sponsorship declared. Just in terms of other work that I'm involved in as well, as Vicky's mentioned, sort of training and events. So we have arranged for a record keeping audit webinar to take place on the 8th of January. That's 1 till 2 on Teams. There's no need to book for that one. Hopefully you've all had the communications come out via your regional network chairs. We will also put the link in, and I've got posted to share with you as well for that one. The Health Innovation Network, the second webinar of those, which as Vicky's mentioned, that's with our NQICAN co-opted member, Sarah Chesil. That will be coming in spring 24, and the recording of the first webinar of that series is also already available on YouTube if you look for the Dorset Innovation Hub. The 2023 Clinical Audit Awareness Week, as you might remember if you were involved in those, our Lunch and Learn events, those recordings are also available on YouTube for anybody who might have missed them. And in terms of our training directory, that it was written a number of years ago. That update is still in progress, and as soon as we have an update on that, obviously we will let you all know. But please also, if you do have any ideas for future training and event topics, please do raise those through your regional network. And like we've said, we can always put you in touch with your regional network. If you are not yet a member, just get in touch through our email address. And that's posted there if anybody hasn't seen it for the Record Keeping Audits webinar. We all know there is no one size fits all when it comes to record keeping audits. So what we're doing as part of this webinar is just sharing examples from 4 clinical audit providers, from 4 NHS providers and the clinical audit teams within them, just in terms of examples of what people have done. So you can take some ideas, some inspiration in terms of what other people have done. So I do hope you will all join us there. And like I say, I'll make sure that that is circulated in the chat as well. So that's that. Yeah, so back over to you then, Vicky.
Oh, lovely. Thanks, Marina. I was just quickly having a quick look at the chat. So, Craig, you're right. East Midlands are also looking for a new chair and a deputy as well, just to add that in as well. So lovely. So I think we've just got a couple of minutes to see if anybody's got any questions for Marina or I before we hand over to HQIP for their update. So if you've got any questions, do you want to raise your hands? And if not, we will... Oh, lovely, Rebecca.
Thanks. Sorry, just at the last minute there. I've just popped in the chat if there's a link for the record keeping audit webinar, because that would be really good to go to. So I want to get it in my diary now.
Yeah, absolutely. I'll pop that in the chat in just a second.
Lovely, brilliant, thank you.
And we've got another query in the chat as well about someone's having difficulty registering, saying that their email address is not allowed to register. It looks like that might be for the Futures platform. There should be a help function through the Futures platform. Unfortunately, we don't manage the admin behind that. But if you check on the help options, and if you're still struggling, do drop us an email, Adina, and we'll see what we can do to support.
Okay,
Brilliant.
thank you.
Yeah, and we can have a look at that later today. I'll log into the platform and have a quick look as well. I think Samantha's just put a question, any other hospices in this current group? Yes, there are, Samantha. It's, I think we've, oh yeah, Bob, you've replied already. St Margaret's is down there. We've got a few hospices in some of the networks. I know we've got one in the East Midlands network as
We've got
well.
two in the East Midlands, yeah, the East Midlands, they've got
yeah.
Ashgate Hospice, they've got Rainbows Children's Hospice. I think there's quite a number dotted around all over. So yeah, absolutely, if anybody's part of a hospice, please do get in touch with Samantha then.
Lovely, thank you. So I think, not seeing any other hands, so I think we'll move on now then, and we'll hand over to HQIP. We should have Caroline, Kim and Helen with us, and also Chris has joined us today as well, which is lovely to see. So we'll hand over to you. I think we can move on to the next slide, Marina.
Yeah, we've just got one question that's just popped in relation to the Education and Training Directory, asking, is there any possibility of developing an e-learning package for clinical audit to go on national ESR? That'd be really good, wouldn't it? It's something we can certainly have a look into, and yeah, I don't know the answer at the moment, but we can.
I would, yeah, I'd definitely urge anybody that's not done it yet to do the e-learning, the online package that's on HQIP's website. So initially developed, I think, when they were looking at the information to support the trainees getting involved, but it's applicable to any healthcare professionals, and it's really good as well. So go head on over there and have a look at that. And I know that there's a little bit of talk nationally about looking at some specific clinical audit education and training resources as well. So yeah, you're right, Marina, we can go away and have some more discussions on that. Lovely. Right then, so hopefully we've got Caroline, Kim and Helen with us, and we'll hand over.
Yes, thank you very much, Vicky, and thanks, Marina. Yeah, just to say good morning to everyone. My name's Helen Barron, and I'm a project manager at the Healthcare Quality Improvement Partnership. I'm going to begin our update this morning. So just by way of an introduction, so with me this morning are Caroline, one of our associate directors, Kim, our head of patient and carer engagement, and as Vicky said, Chris Gush, our new CEO, has joined the meeting this morning. So I think I'm going to hand over to Chris now to say a few words before we continue with our update.
Thanks, Helen. I just wanted to introduce myself, really. Jane had been Chief Exec at HQIP for an awful long time and done an incredible job. So I've got some really big shoes to fill there. But I thought I'd introduce myself to everybody and just let you know if anyone's got any questions or suggestions or wants to talk about the work we do. Obviously, the team that are going to talk to you now are superb. But if you want to talk to me, my door is open. So please do come and contact me. You can find details on the website for that. So thanks a lot. And Helen, I'll hand back over.
Thank you very much, Chris. Yeah, Marina, I'm happy to go on to the next slide if that's okay. That's great, thank you. So as usual, I'm going to start with a brief update on the quality accounts list, the directory, and on the NQICAN subscription activity. So yeah, that's great. Thanks, Marina. So in terms of the NHS England quality accounts list, just to note again that the process to develop the 24-25 list is now well underway. Audit provider responses to the scoping survey are being reviewed at the moment by NHS England, and the list will be made available in advance of the new financial year. So we have plans to publish that on the HQIP website probably by mid-January 2024. And further information, as always, can be found on the HQIP Quality Accounts webpage. So yeah, moving on to the directory. And just by way of a brief introduction, or I suppose probably a reminder for most of you, the directory is designed to be a tool or a resource, and it's for guidance or information only. So it's really almost like a starting point to further investigation into specific questions or looking for more detailed information. The directory includes NQICAN projects and other projects listed on the quality accounts list, but there are also other projects listed in the directory, so it's not necessarily a list of projects that trusts must participate in. The latest version, I think, at the moment on the HQIP website is dated October 2023, and a new version will be released in the coming days. That's great. So just going on to the annual review slide, please, Marina. Thank you. Yeah, I wanted to mention really that work is underway on our annual review of the directory, looking at the directory fields, as well as looking to include new details for the 24-25 financial year. This revised version will be made available following publication of the quality accounts list. As always, we would welcome any suggestions or feedback on the directory. So please feel free to email me directly. My email address is there on that slide. And just also to note that in the meantime, the directory will continue to be updated on a monthly basis, as far as possible and as needed. So new versions, as usual, will be posted on our webpage and signposted via the NQICAN online forum. So finally, just a very quick update on NCPOP subscription activity. We now have purchase orders from, I think, 97% of trusts and payment from 90% of trusts. So we're making really good progress on the 23-24 funding. So thank you very much for your time, and I'll pass you now on to Caroline, I think.
Yes, it's me. Thank you. Can everyone hear me? Yeah, I'm getting nods. Hi, morning. Caroline Rogers here from HQIP. Hopefully lots of people know me, but I'm one of the HQIP team. I'm an associate director there. So could I have the next slide, please? Thank you. So I'll do a quick run through some of the work of the NCPOP programme, and we'll do questions at the end in the normal way, and happy to answer any questions. So to let you know, there will be a brand new audit, National Eating Disorders Audit, so quite a wide-ranging audit of different kinds of services that deliver eating disorders care, and that tender has been open and has now closed. So we are in due course, we will run the normal procurement process, and that will be announced. And the second procurement activity that we're doing recently is the mental health clinical outcome review programme, and that's been running and is now being evaluated. So that's a recommission. Next slide, please. So since the last report, so there's a link there, and they're all on our website. As people may know, all of the reports from the NCPOP programme are always published on the second Thursday of every month, so it's Superstats Thursday. There have been quite a few. So to name a few, we've got quite a few diabetes reports, arthritis, neonatal audit programme, stroke programme, falls. So lung cancer audit data has been released. So a wide-ranging selection of reports and data being released the last 2 Thursdays, and more will be published next week. So as always, reports are on our website. The links are there. Thank you. Next slide, please. And a couple of other pieces of work we've been doing. People have been working quite hard to revise our outlier guidance. So this is the guidance that NCPOP give to our providers, so all the audit teams, about including about how they should manage and advising on managing outliers in the programme. And this will be published soon. So we've been doing some work with NHS England on this outlier guidance. So you will see that come out. And this is about the information that the audit providers write to trusts about their results and our outliers and the process that we go through, working with the CQC, working with other bodies to do that. A couple of big changes are some more information about what to do in circumstances where trusts are not participating, and looking at the data quality and the data completeness. Oh, thank you. And the second report I wanted to mention that we have recently published is improving health inequality data in the NCPOP, and that's a project that was carried out by one of our clinical fellows, Alice Bradley, last year to identify and explore the barriers to health inequality data that we have in the NQICAN programme, and she's made a number of recommendations, and we've adopted and published this report and recommendations about getting good data, inequalities data in the NQICAN programme. Next slide, please. So hopefully everyone's seen, this is our Quality Improvement Magazine Cornerstone, and yes, there is an article from Vicky, so thank you. There's lots of good, exciting, interesting articles in there, so I'd encourage you to have a read. It's free, you can download it now, and it's there for everyone, so just to draw your attention to that. And I think I'm now going to hand over to Kim, if I'm right. So next slide, please. Thanks.
Yeah, that's fine. So we also, the comms team wanted us to share information about a new blog article that's written by our new current clinical fellow, which is Dr. Claudia Snodden, and Drew Smith, one of our other associate directors. And they've written about the challenges and opportunities that AI offers. So very topical. So they look at 2 ways that generative AI can add value to national clinical audits, specifically data analysis and content generation. So you can find that on our website. The comms team have also been highlighting winners from this year's Audit Heroes from Clinical Audit Awareness Week 2023. And they've recently published a case study from the winner of the Influencing Organisational Change category, Ella Howard, who is the assistant psychologist for the Emotional Health and Wellbeing Service in Cambridgeshire. She writes about how the peer-to-peer clinical record keeping audit supported meaningful change at board level. So you can find out more on that. Next slide, please. So last time, hopefully you were all here and you heard from Susan Gillespie, who's our project manager for the NCAB. And she gave an extended presentation about it. So we hope you found that really helpful. New data has been added to the platform recently from National Prostate Cancer, the National Vascular Registry, and the National Ophthalmology Database Audit been added since the last meeting. So the NCAB continues to be updated in conjunction with the CQC, and we welcome feedback. So please do email on that link there. Next slide. Really excited to tell you about a new project that we've been funded by Health Data Research UK, which is to explore public involvement in our data access processes. So we'll be exploring best practice and enabling members of the public to be involved in our health data access group that we have. So we've just started work on this, and it will run until March 2024. We're currently recruiting some of our service user network members to join us on the project team. I can tell you that we've received 14 EOIs, so we'll be shortlisting this week. It's really exciting. Next slide, please. And just to tell you a bit of my work at the moment, work continues on the maternity project. I updated you on that last time. This is a project for NHS England, and we're looking at what matters most to maternity service users. And we're currently running a series of engagement activities where we're asking seldom heard communities. So we've got focus groups with LGBTQ+, refugees, people who experience extreme sickness during pregnancy, and we're running these engagement activities now. Also, for the National Obesity Audit, we have completed 2 pieces of guidance, which we co-produced with a youth panel that we established last year for this project. And it's to support service users to access the National Obesity Audit dashboard. So I'm working with the comms team now on the intro to the audit guidance, and so that should be on our website soon. But we'll be working with external designers for the dashboard guidance, so that hopefully be published early in next year, so January is the plan. I already mentioned the Health Data Access Project, and the usual information here to ensure you use our resources and to let me know of any PPI work that you guys are doing in quality improvement. I'd love to hear about it. And I think that's it from all of us. So if there's any questions.
Thank you, that was great. It's always good to get the latest coming out of HQIP, just so we know we've just not missed anything at all. So has anybody got any questions? Do you like to raise your hands? Opportunity whilst we've got Caroline, Kim and Helen here, and obviously we've got Chris with us as well.
I just saw a question about sharing a link to the maternity. So at this stage, there isn't a link because we're doing the engagement work. Once we've completed it and we have our findings, we will share that.
Lovely, thanks, Kim. Okie dokie. So we've got no hands. No hands at all. So I think.
Were there any questions in the chat, Vicky?
I didn't see them, just the
Oh,
one
I
that
thought there was one.
Kim said. I'm just scrolling back
there was a question. Has the cost for quality accounts changed this year?
Is that it? Does that relate to subscriptions? Do you?
Yeah.
Yeah.
I think that's the NQPOP subscription rather than quality accounts. Yeah.
Yeah. Well, I guess I mean, in terms of the cost associated with quality accounts projects, I guess we're still working on we're still finalising the list, so we're not at the position to be able to say in terms of whether there's more subscription cost associated with that. And the NQPOP subscription, this current year, it's the same as it's been, I think, for several years previously, and no decisions being made on what happens in the future. So yeah, that's it.
Lovely, thank you. I think we've just got one other comment from Di just about the health inequalities reports, very welcomed, which is good. That's really positive. Yeah, I think that's it. I can't see any more. I've just gone all the way back up again, so hopefully, but obviously keep posting any comments and everything into the chat, because we'll obviously pick things up at the end as well, and if you then have a further thought or a further question. Thank you so much, that was brilliant, thank you. So I think we've got Dr. Handley Cole joining us from LEDAR. So Emily, hopefully you're on and you can unmute, and we'll move on to your slides, please.
Hi everyone, nice to meet you. So my name's Emily Handley Cole and I work for NHS England as part of the LEDAR programme in the Learning Disability and Autism team. I'm a clinician by background, so I spent most of my career working in mental health services for people with a learning disability. I'm a clinical psychologist. So yeah, here to talk about the LEDAR programme, what it is, what we found, and hopefully to have some discussion about what that means for you in your roles and in your organisations. I'm just going to share my slide deck. Hopefully technology is on my side and lets me do that smoothly. So far, like it might be behaving. Fabulous. Hopefully you can see that. Yeah, and my intention is to leave some time for questions and discussion at the end. So So what is the purpose of LEDAR? Hopefully the majority of you will have heard of it, but I will give a brief overview of what the programme is and what its intentions are before talking about some of the findings of the LEDAR programme. We actually, this presentation is quite timely because we published our annual LEDAR reports last week, so I'll be able to tell you the latest data. So it's a service improvement programme which aims to improve care and reduce health inequalities and prevent early deaths of people with a learning disability and autistic people. And we do this by reviewing the information about health and social care support that people receive. And unlike most mortality review processes, the LEDAR programme looks not only at the final episode of care and the events leading up to the patient's death, but it also reviews the kind of health and social care provided to the person throughout their life as well, so that we can really learn about kind of proactive care throughout life, but also missed opportunities for proactive and preventative health care. It's very much an ICB-led local service improvement programme, and the requirement is for ICBs to review all deaths of people with a learning disability and autistic people, and to drive service improvement locally based on that learning. There are leader governance groups within each ICB who look at the findings of individual leader reviews and identify action plans, which are usually multi-agency, multidisciplinary action plans to drive improvement. But there is also a requirement to respond to kind of thematic learning, so looking at the theme across a region and also the themes that come out at a national level. And the report which I spoke about earlier is our kind of national report, which provides an analysis of the findings of all the deaths that are reviewed in a given year. We also have a national leader team within NHS England, and we put out initiatives that are aimed at improving outcomes nationally. So to give some examples, we found in recent years that respiratory health and respiratory deaths are causing a big problem for people with a learning disability, but both before COVID and also as a consequence of COVID, through which people with a learning disability were particularly vulnerable. And we've worked with organisations like the British Thoracic Society to put out clinical statements on sort of proactive aspiration pneumonia care for people with a learning disability. A couple of weeks ago, we published some guidance on using CPAP machines for people with sleep apnea who have a learning disability. So we're regularly kind of publishing resources and putting out initiatives to address kind of national themes and national findings. As I've already said, LEDAR reviews all of the deaths of people with a learning disability, and we've done that since 2017, so we have quite a significant quantity of data now. And the deaths of autistic people were introduced to the programme in 2022, and you'll notice when I go on to talk about the data, because their introduction to the programme was quite recent, we have a very small sample size in relation to autistic people at the moment, but that will certainly grow over the coming years. When the programme was first rolled out, we also reviewed the deaths of children through LEDAR, but a recent change means that child deaths are now reviewed solely through the child death overview process, and those findings are linked to the LEDAR database, and they kind of that data kind of is extracted into our database to reduce duplication and the risk of deaths being reviewed twice. LEDAR doesn't replace formal investigation processes, so as you can probably imagine, particularly if we're talking about premature or preventable death, there are often other processes involved, such as inquests, safeguarding investigations, sometimes complaint processes or serious incidents investigations, and they are also followed. LEDAR doesn't replace those. In fact, sometimes LEDAR is a LEDAR review is put on hold pending the completion of those processes. So just to give you a brief insight into what the process involves, as a minimum, each review would involve a guided conversation with a family member or somebody close to the person who died, if family aren't sort of still in touch with the person, or if family decline to participate in the review. There'll be a detailed conversation with the GP or review of the GP notes, and a conversation with at least one other person who was known to the person who died. So that could be another family member, another sort of care, or somebody who knew the person well, or it could be a representative from sort of a provider agency, like a foster care agency. So we've just published LEDAR annual report. I can share these slides with you, and the web link is available there. But also, if you just Google KCL for King's College London LEDAR annual report, you'll find a copy of our latest report, which was published on Thursday. So I'm going to go on now to tell you some of the findings that we've published in our most recent report, which highlight the level of inequality and poor care that people with a learning disability continue to receive in the context of the NHS. It's very heartening to see some improvements, I think, kind of really manifesting quite clearly in the report for the first time this year, which shows the impact that reviewing deaths consistently and having this kind of quality improvement cycle is having. So yeah, as well as sharing with you some quite stark messages about the extent of inequality, I think there's also some heartening messages about the difference that service improvement activity can potentially make to this patient group. So the average age of death of people whose deaths were reviewed this year, so apologies, these are deaths that are reviewed, deaths that took place in 2022. That's our most recent data, because obviously it takes time to review deaths, and if the review is on hold because there's an inquest or investigation, etc. So that's why there's always a lag between date of death and publication of the data. So average age of death in the most recent year's data was 62.9 years. That's compared to, oh, I don't have the figure off my head, but 80 point something in the general population, depending on if you're looking at males or females. So we continue to identify a 20-year disparity in the average age of death for people in the general population compared to people with a learning disability. It is increasing over time since the inception of LEDAR, and actually the fact that it's increasing, albeit only slightly, by sort of a year or two, depending on if you're looking at child deaths or adult deaths. The fact that this increase has been seen despite the COVID pandemic, I think is very encouraging, because people with a learning disability were 6 times more likely than the general population to die with COVID. So I might have expected kind of a significant decrease in the average age of death of people with a learning disability as a result of the pandemic, and we actually haven't seen that. You'll see this graph shows a comparison to the general population for the early years of the LEDAR programme compared to 2022. So obviously people in the general population much more likely to die over the age of 65 than people with a learning disability, but a slight increase in the sort of the first 2 columns in each set of 3. So in 2018 to 2021, that the number of people dying in each age group has sort of started to increase. Apologies, just having a bit of a lag with my slides now, which they're not wanting to change. Nope, they're completely stuck. That's not helpful. Bear with me, just give me 1 second and I'll see if I can problem solve.
Would you like me to share them for you?
Yeah, although I've completely lost my screen. Let me just open my laptop. Yeah, that would be helpful actually, if we can. Stop presenting. Thought technology was really on our side today.
There we go, it should be up now.
Can you see those, Emily?
I can't at the moment, no. Let me see.
We're just on your graph slide at the moment. I don't know if you can remember your slide order.
If you'd have asked me last week, I probably could, but because we've just published new data, I haven't reached that level of obsessive knowledge yet, unfortunately. I will get there very soon.
Don't know if you
Can
can
others see the slides?
refresh or... See if Emily's going to leave and rejoin us. Thanks, Rebecca. You've shared the link in the chat. That's brilliant. The link's there to the LEDAR work. Craig's saying their slides are stuck for him, but I think we've not moved it on, have we, Marina?
I'm currently sharing the slide that's median age of death.
Yeah, lovely.
Right,
I think Emily's back.
Can you hear me?
We can.
Fabulous. Sincere apologies, everyone. That was not very smooth. I've just unplugged my laptop from my monitors and that seems to have resolved the issue. So yeah, thank you for your patience. So I was talking about median age of death and just moving on to the next slide, I believe, if I recall correctly. Okay, so yeah, obviously age of death is sort of a helpful indicator to us of the quality of care or opportunities to improve care for people with a learning disability. Another measure that we look at is avoidable mortality. And unfortunately, again, there's a very stark comparison in the experience of people with a learning disability compared to the general population, whereby 42% of deaths of people with a learning disability are deemed as avoidable compared to 22% for the general population, so almost double, which is scandalous, obviously. But then when we also think about the percentage of people with a learning disability who have paid carers, who are reliant on other people, who are in supported settings, I think it's almost even more scandalous. Potentially also talking about a group that may lack capacity to make decisions, so they're reliant on other people to make safe and sensible decisions about their kind of the food that they eat, the exercise they do, the type of lifestyle that they have, the medications that they access, the preventative kind of vaccination programs that they access, etc. So if anything, you know, and maybe this is a bit of a stretch, but you could argue that you might expect to see lower avoidable death amongst people with a learning disability compared to the general population. So again, that just makes this statistic even more scandalous. What is good, though, is that last year, when we published the previous year's data, it was 49%. And actually, I think a difference between 49% dropping to 42% in the space of a year, particularly given that we've had the COVID pandemic and that COVID deaths are classed as avoidable, I think it's a sign that with quality improvement activity, we can make good steps in the right direction. But there's still a lot more work to do. And I should say, perhaps for those of you who don't know, that kind of classification of avoidability, it's based on a set list of conditions that are classed as avoidable across Europe. It's not a subjective judgment made by reviewers that somebody's death was or wasn't avoidable. It's based on sort of an official list of deaths that are classified as avoidable or not. And that's usually based on whether they could be prevented or treated with high quality healthcare. Fab, if you could advance the slide, please. So thinking about causes of death, there are different ways of looking at cause of death, which makes this slide come across as potentially complex, but I guess it's just giving us insights from a number of different lenses. So when we think about common causes of death by ICD-10 chapter, which is kind of a grouped classification of cause of death, deaths caused by diseases of the circulatory system are most common, followed by cancers, respiratory system, nervous system, and then others. If we look at underlying causes of death, which are the kind of bottom line on the death certificate, respiratory conditions and cancers are featuring highly there, as well as conditions of the nervous system, including epilepsy. And I've got a slide later which shows how common epilepsy is amongst people with a learning disability. And then another way of looking at cause of death is based on the World Health Organization categories of leading causes of death. So these are deaths that are sort of found to be very common and prevalent in the general population. And congenital malformations and chromosomal abnormalities feature very highly here, as well as cancers, flu and pneumonia, cerebral palsy and ischemic heart disease. So some overlap there in relation to cardiovascular, cancers, respiratory, typically featuring very highly. Next slide, please. Reminding myself of Chris Whitty there, taking me back to pandemic times. And next slide, please. So long-term conditions are, yes. So this provides insights, this slide provides insights into the long-term conditions that people were diagnosed with at the time of their death, not necessarily the cause of their death, but the long-term conditions that people are living with. You'll see that mental health features very highly here, as well as cardiovascular disease and epilepsy, amongst others. Next slide, please. So thinking about circumstances of death, and we're sort of starting to move into thinking about kind of quality of care here, and I think these slides start to give you some insights into the types of areas that require improvement if we're going to see a reduction in inequality and ongoing increase in average life expectancy for people with a learning disability. So 74% of people whose deaths were reviewed had a DNA CPR in place at the time of their death. And reviewers judged that these processes and protocols were correctly followed 63% of the time, which is a slight increase from the previous year, where they were only judged to be in place and followed correctly 61% of the time. But that does leave us with kind of a situation where for nearly 40% of the people whose deaths were reviewed, DNA CPRs were not appropriately in place, and that means protocols weren't followed. Also situations where people had a DNA CPR just solely on the grounds that they had a learning disability and no other reason, which shows the kind of value judgments and unconscious bias that perhaps clinicians can be at risk of having if they don't have extensive training about what it means to have a learning disability. So a lot more work that needs to be done in that area, as well as situations where DNA CPRs might have been put in place, and perhaps clinically there are grounds for that to be so, but the person hasn't necessarily been included, or their parents, carers, paid carers haven't been included either. So you know, we can just begin to imagine the impact that could have on a grief experience if somebody died and the people that loved them didn't know that there was a DNA CPR in place and hadn't been involved in those preparatory conversations. Referrals to a coroner are increasing. That potentially sounds like a negative finding, but I would see that as a positive finding, because historically the percentage of deaths of people with a learning disability referred to a coroner were much lower than the general population when we're talking about a group that are experiencing high levels of preventable deaths. So I think what that was showing us was that there wasn't the right level of scrutiny and learning into these deaths. But over the course of the LEDAR programme, rates of referrals to the coroner have increased. So yeah, 36% in the general population and 25% amongst people with a learning disability. So again, some way to go, but improved reporting. Also, the Mental Capacity Act. We found that in 25% of cases, the Mental Capacity Act wasn't correctly followed. So again, that could make the difference between life and death. And, you know, we see situations where somebody's perhaps not had the assessment procedure that they need because people don't want to upset them, rather than actually thinking about what's in this person's best interest. Is there a reasonable adjustment that could be applied to their care, such as sedation, or actually do we need to cause this person a small amount of distress to save their life, etc. So a long way to go there in terms of understanding and application of the Capacity Act for vulnerable patients. Next slide, please. So place of death. So we're seeing a higher rate of deaths in hospital for people with a learning disability compared to the general population. And this hasn't changed significantly over the course of the LEDAR programme. I think in some ways it's to be expected, given that we're seeing a higher number of premature or perhaps unexpected deaths compared to the general population. But if we think about end of life care and the rights of people with a learning disability to make their own decisions, choices, have the option of dying somewhere where they're comfortable, surrounded by people that they love, then there's probably work to be done in terms of skilling up the workforce within care homes and supported living settings to have the confidence to support somebody to die at home if that is their choice. Next slide, please. So yeah, this is the other area which remains a significant problem for people with a learning disability. So if the 20-year disparity in average age of death for people with learning disability compared to the general population wasn't startling enough, this is even more so for people with a learning disability from minority ethnic backgrounds. And for some minority ethnic groups, the average age of death is as low as in the 30s for people with a learning disability. So a huge amount of work that needs to be done there. And our academic partners did some statistical analysis looking at people from different minority ethnic groups and their risk of dying in the near future. And you can see that it's startlingly higher for people, for example, from Black, British, Caribbean or African backgrounds. It's 190% more likely than people from white ethnic backgrounds. People from Asian or Asian British, 150% more likely. So a huge amount of work needed there. We have this year commissioned the Race and Health Observatory to do some work, and they've recently published, well, in the spring, published a report on people with a learning disability from minority ethnic groups, and they've listed a number of recommendations for the NHS in terms of some ways that they can go about addressing these inequalities. But this does need to be a priority for the NHS. Next slide, please. So yeah, factors associated with age at death. So again, this extrapolates from the statistical analysis that was done by our academic partners. So epilepsy was found to be the long-term condition that was most strongly associated with dying at a younger age, and epilepsy is much more common amongst people with a learning disability than the general population. I think off the top of my head, I think I'm correct in saying that 1 in 3 people with a learning disability have epilepsy, which is obviously very high. We did some work this year with SUDEP Action, which is a learning disability charity, who've published some easy read resources and videos and information for carers and also clinicians, because we see a pattern of overprotection where perhaps people with a learning disability aren't included in conversations about how risky epilepsy can be, which means they're left not realizing that they could die if they don't take the medication, or if they, you know, aren't supervised when swimming and those types of things. So hopefully that work will make a difference. This the second point on this slide should go without saying, really, but I think is also quite poignant. So the statistical analysis found that appropriate care was associated with reductions in premature death. So if people have a good package, carers that know them well, reasonable adjustments provided to provide personalised care within the NHS, then they're less likely to die young. Probably should go without saying, but it is helpful that statistics support that finding. Next slide, please. So yeah, quality of care. The reviews also find evidence of good practice, which is helpful, and sort of ICBs and regions tell us that for sharing examples of case studies, good practice, what good looks like, can be really valuable to stop people having to kind of reinvent the wheel or start from scratch. And we have seen kind of an increase in the examples of good practice that are identified, the number of reviews in which some good practices has been identified over the course of the LEADER programme. But when there have been problems of care, it's a very familiar list of reasonable adjustments under the Equalities Act not being available for people, communication of information and transfer between teams and organisations being poor, transition issues between children's and adult services. So quite a familiar list there. Next slide, please. So in terms of excess deaths, this is a term that the ONS, the Office for National Statistics, uses to refer to deaths above the 5-year average. One pattern that we noticed for the first time in the LEADER data this year is an association between the very hot days in July 2022. I don't know if you remember that kind of heat wave where we were in the kind of top 30 degrees Celsius, hitting 40 degrees Celsius, and an excess of deaths specifically on the hottest days were identified. It's difficult with a programme like LEADER, where the deaths are reported manually to us. It's not automated, so we don't automatically hear about all the deaths of people with a learning disability. It can be difficult to say that the correlation is absolutely due to an excess of deaths rather than just because we received more notifications in a given year. But if you look at the following slides, it shows a graph which summarises the temperature. So I think, yeah, the temperature is the top line on the graph by day, so by individual day in July 2022, and the line on the bottom is the date of death for people with a learning disability, and you can see that there are really clear peaks where the hottest days have led to the highest number of deaths. And apologies to mess you around, if you could just take me back to the previous slide. We found that the most common causes of death during these peak waves were respiratory conditions, cancers and cardiovascular conditions. So I think historically as a programme within the Learning Disability and Autism programme, we've always focused on putting out information in the winter about helping people to stay warm, and actually we really also need to focus on the information that we're putting out to people with learning disability and their carers around hot days as well, and I suspect this would also apply to other vulnerable groups. Okay, next slide please, and if you whiz past the graph as well. Okay, so I'm not going to talk at length about the deaths of autistic adults because, as I said, this is the first time that group have featured in our annual report. We received notifications of 110 deaths, but only 36 had a completed review by the time we finalised the data for publication. By definition, at the moment, we're more likely to hear about the deaths of autistic adults where there are other investigation processes underway, because they're more likely to land on the desk of somebody that knows of the requirement to report to LEDAR. So you can see that very sadly, we had a high number of deaths due to suicide, misadventure or accidental death. Because of the small numbers, we can't draw conclusions from this data. It wouldn't be appropriate to say a third of the deaths of autistic people were due to suicide, for example, but we do know that suicide is a significant issue in this patient group, and we are rolling out an awareness campaign over the coming year so that we receive more notifications of the deaths of autistic people, so that we hopefully have some more accurate and sort of statistically valid insights when we publish our report next year. Next slide, please. But the kind of emerging sort of thematic early learning that's coming from quality concerns identified in the reviews of autistic deaths include a lack of high quality training or awareness of the specific needs of autistic people, lack of adequate support services, so lots of people presenting in the NHS who are much less likely than people with a learning disability, for example, to have a supporter, a carer, an allocated mental health worker, for example. The impact of relationship status change seems to be significant for this patient group and often overlooked, and also a number of patients where there was a lack of crisis escalation plans or even awareness of the increased risk of suicide in autistic adults. Lack of communication between different professionals, and also overshadowing of the impact of autism by other co-occurring mental health conditions. So like I say, they are early findings, a lot of focus on mental health there, as you would expect, due to the number of deaths that we reviewed that were due to suicide. But yeah, we will be working to improve rates of notification of autistic deaths so that we have more to share next year. Okay. So yeah, as well as publishing our report about the deaths of people with a learning disability, and that gives more information about the data that I've just shared, we also have Just Report an Action from Learning report, which gives some examples of local, regional and national initiatives that are being rolled out in response to learning from LEDAR reviews, and that report was published on Thursday as well. So do look there or share that with your networks if you think that would be useful to your audiences. And I think that was my final slide, if I'm not mistaken. Yeah, so apologies, I've talked for a very long time, longer than I planned to, not helped by the technical issues, but yeah, I guess I just invite you to think about what this means for your audiences. We've seen the really clear impact that improvement activity can have on outcomes. Yeah, and I'm happy to answer any questions.
Thank you, Emily. That was really insightful. You've definitely delivered that with impact. I'm sure I can say that on behalf of everybody on the call. That was brilliant. I can see we've got a couple of comments in the chat. I'm not seeing any hands yet, but I'll keep an eye out. So Beth's asked, did you collect any data around maternity services?
Not specifically, no. I think there are questions in the LEDAR review about maternity, although I would have to double check that. I'm happy to take an email if that would be useful. It's not something that has come up as a strong theme so far. I suspect it may well do once we start receiving more deaths of autistic people.
Lovely, thank you. Not seeing anything else in the chat, and I'm not seeing any hands up. You mentioned governance groups at ICBs, which I've just made a note of, Emily, as well, in terms of, I'm just thinking now for people on the call, and obviously as sharing this wider with NQICAN, because obviously we'll save the slide packs alongside the recording on the forum and make sure our members have got access to it all. But I suppose it's probably about encouraging people to make contact then with who they need to, maybe within the ICBs, for looking at those local action plans then that are being formulated with the governance groups and accessing those resources. But furthermore, I was thinking about people going away to their own organisations and finding out how we are notifying LEDAR of these deaths then, because it sounds like you're not being notified about all of them.
Yeah, certainly autistic deaths, and also deaths of people from minority ethnic backgrounds as well. We have a much lower rate of reporting amongst those groups. We're also less likely to hear about deaths of people with a mild learning disability because it's less likely to be on their records. But actually, those are the groups where a huge amount of learning could come that hasn't emerged yet. So anything people can do to encourage notification would be very helpful.
Brilliant. So we can we'll try and take that away as an action as well. And I know we've had a couple of comments about people contacting their safeguarding team with the slides, and then obviously whoever's leading on end of life care as well, then potentially, as you've obviously picked up on, place of death might not necessarily be, you know, if patients have highlighted that they want to die at home, then obviously us trying to make contact to make sure we're getting that right as well. Oh, lovely. Hayden, you've got your hand up. Would you like to unmute and ask your question?
Thank you. It was just I did come in late to the presentation, so apologies. I will be going back and looking at the start of the slides because I found the back end fascinating. Whenever we've seen them, these reviews, the LEDAR reviews, there's always a pen portrait that's attached to them. And I think if for anyone who hasn't seen these reviews in your organisation, it's a plea to go and check these out and look at these, because I think how the personalisation on these, particularly on these reviews, is incredible. And I think sometimes with these sort of external collaborative reviews, it's easy for it to become impersonal and sort of stating the facts. And I think the LEDAR reviews are the opposite. Obviously, they're still factual, but equally they've got a real personal touch to them that I think is incredible, and something that's really valuable that we use here at Catcher General, and I'm sure many other trusts do as well. But thank you.
Brilliant, thank you, Hayden. That's really helpful. Yeah, and if I had longer, it would be really helpful to add a case study to these slide decks, actually, or a real life story is a nicer way to say it, because it does really bring it to life, doesn't it? And our action from learning report, which I just mentioned at the end, and the link is on the slide, there is a story in that as well, of kind of what good care looks like and the difference that can make. So people can visit that if they're interested too.
Yeah, no, it's brilliant. Thank you, Emily. I think we'll make sure we take this forward, and we'll take it as a key point into our regional network meetings as well, for more local discussions across our systems, really, and how we can pick up those resources, which is really good. Thank you.
A couple of additional comments that have come in the chat just while we've been talking. So we've got one from Diane Lynch. Excellent presentation. I was just wondering if perhaps that information you presented could be a benchmarking documents for trusts. It may already have one.
Yeah, so actually there is a benchmarking, there's a learning disability benchmarking document. What I can do is try and dig out the link for you and send that in the chat. I think it is something that is available online. I'll just have to double check that, but that is very much informed by the findings of LEDAR and updated each year based on the findings of LEDAR. So yeah, absolutely, great idea.
And then there's another one from Emma Botting. Do you know how gender impacts on deaths of people with autism?
Not yet, because the data is so small. There's only 36 deaths, so doing anything kind of statistically significant, but that's definitely something that we'll be wanting to look at. And we do record, we ask reviewers to record whether somebody's gender is the same as their sex at birth as well, because there's likely to be some learning there. I think in the learning disability group, interestingly, for the first time this year, we found that if you are male, then you're more likely to die an avoidable death than if you're female. We haven't had a chance to do any digging into why that might be, but yeah, gender and sex are definitely things that we are looking at, and I think particularly with the autism group, that will be important to look at as our data size increases.
Lovely, thank you. Don't think, are we, oh, hold on, let's just check. Yeah, no, I don't think there's anything else, is there, Marina, in there? the chat scrolling up. Thank you so much, Emily. That was brilliant. Thank you.
Okay, brilliant. Thanks all.
Thank
And thank you
you.
for my patience with my tech issues.
Oh no, we didn't want to miss any information from you, so thank you.
Thanks.
I think we've got, and so Chris, I think Chris O'Connell's with us from NICE. I think we'll move over onto the NICE section. Lovely, brilliant, thank you.
Right. Good morning, everybody. Are you guys going to be using the running the slides from your end then? That's fine if you are, or I can.
Yeah, we can run them from this end. Just let me know when you want me to move on.
Okay. There's only, I think there's only 6 or so. Good morning, everybody. Thank you ever so much for inviting me back again. I'm Chris Connell. I'm Associate Director with NICE's field team covering the southwest of England and Wales, but here on behalf of the whole team this morning. You can see the kind of 4 areas I'm going to cover, which I think, building on from last time, most of you will have links with your regional networks, and that'll give you the opportunity to get into detail over some of these areas if you want, and also to ask more detailed questions on other topics. But this is some of the kind of headline stuff that's going on with NICE at the moment. So it's topic prioritisation, why we do what we do. Question we ask ourselves sometimes. A little bit about embedding technology appraisals into guidelines, and that might link in with some of the comments I made last time about virtual living guidelines. Some work we've done on virtual wards, which may be of interest to people, and just to highlight recent guidance and recent forthcoming guidance that may be of interest to you as well. So next slide, please. Right. One of my colleagues the other day, I don't know how they did this, but it's been calculated that we've got something like 26,000 guidance recommendations coming out from NICE altogether. I'm guessing some people here will probably kind of suffer the consequences of that. So on one level, that is great. Lots of evidence, lots of recommendations covering pretty much most areas of health and a lot of areas of social care as well. On the other hand, not so great, because that's pretty broad. How do you keep on top of that? How does guidance link together? How do you audit? How do you kind of even implement that many pieces of that many recommendations? So we've been taking a look at this over the summer, and this is what we're going to be doing. Currently, we've got, believe it or not, 6 different ways of selecting topics about what we choose guidance on, whether it's a guideline, whether it's a piece of med tech, whether it's an interventional procedure or a technology appraisal. So they're all slightly different from each other. There was originally very good reason for those differences, but that has perhaps become what was a good reason has now become a bit of a problem. One of those problems is there's no real central oversight of why we're doing what we do. The final sign off of most of our guidance comes from ministers, but we do believe that we've got a really important role in shaping and helping to inform what ministers decide NICE looks at. So we've got no real strategic view. Other people have got a very fragmented input into the NICE prioritisation process. And we're also missing opportunities where guidance and different types of guidance overlap. And if we could bring things together, if we could link things together better, it would be a stronger piece of guidance. It would probably be easier to implement, and it would certainly deliver more benefits to patients. So what served us well is perhaps now more of a hindrance than a help. So as of April, this is what we're moving to after some consultation. We're setting up what's called a single prioritisation board within NICE. That currently exists as a shadow board as of this month or last month. And that is quite a large board, bringing people from across NICE, and it's going to be chaired, or is chaired, by Dr. Jonathan Benger, who's the NICE Chief Medical Officer, who is also still a practicing clinician, cardiology, I think, down in Bristol. And the aim behind that board is to develop an integrated strategic approach so that we can prioritise and coordinate all our relevant NICE guidance products. So what we do hopefully makes more sense for people such as yourselves. Next slide, please. And as part of that, what we will, the board is developing is what's called a common prioritisation framework. So those 6 different ways approaches being brought together to one, that's going to apply to all the topics and products that we look at. So there'll be a consistent approach in future as to why we're looking at things and why we might not looking at things, and people will be able to see that, so it'll be transparent. The kind of questions you might guess already, you can come up with 10, 20 quite easily. Is there a particular clinical priority? Are there controversies? Are there productivity cost issues? Is there uncertainty about evidence? What are priorities for local and national and NHS England and so on? So that framework will be developed and we'll coordinate what we look at in that way. We're also going to start looking ahead a bit more systematically. And by ahead, we're looking at not just next year or 2 years, but 5 years, maybe even slightly longer, in a horizon scanning approach, which will be bringing together where we think things are going to be going with digital, for example, AI, biologic drugs, what other organisations, what's happening internationally, and trying to feed that in further upstream than we do at the moment. And perhaps be a little bit more systematic in the system intelligence that we get from people such as yourselves and other people working in trusts, primary care, ICBs, and also reviewing what we do with social care. We're going to be publishing from next year an annual forward view to give people a sense of direction of where NICE is going on and all this. It's going to be a report that will include the decisions that we made, the prioritisation for the future, where we think innovation is going to feed in, and why we didn't look at things as well in some certain circumstances. What was the rationale behind that? So hopefully, why am I telling you all this? This is not going to be done overnight, but you will hopefully begin to see this start to play out from next year. So it will be a much more coherent offering from NICE than 26,000 recommendations and some of those things being a little bit loose or people scratching at their heads occasionally as to why we looked at things. So more strategic, more structured approach. Next slide, please. So I've covered that central oversight. What you'll start to see is that guidance will be more clearly grouped according to topics and themes rather than particular individual items coming out. So again, that kind of coherence, the yes and the no decisions, the transparency. And then the last thing, this is kind of trips off the tongue, but is really difficult for everybody here on the call, I would suggest, making sure that we focus on what matters most. Most things that NICE look at matter. Most things that you work with matter. Hence why we've got the 26,000 recommendations and all the guidance that we've produced. It matters to particular patient groups. Just listening to the last presentation, a good case in point. But nevertheless, we do have to try and prioritise, and we hope that this approach will focus on what matters most, not particularly to NICE, but to people such as yourselves, and even more importantly to patients and carers. And also, I touched on this last year, the way that guidance looks will begin to change, so that not only is it's useful in terms of the topics, but it's also a bit more usable than a giant PDF that we sometimes, well, we do tend to produce. So it's more useful both at the clinical level, the patient level, but also at the quality improvement, the audit, the commissioning, the strategic planning level as well. Next slide, please. What is not going to be terribly helpful is if this is all just the view of NICE and what we think. We have consulted on this, and one of the things that we want to go ahead with this prioritisation board, that it has much more transparent, much more systematic input into its decision making from our stakeholders. We have a lot of stakeholders. You can think of the big players, NHS England, the department, and that's great. But also trying to gather more consistent stakeholder intelligence from trusts, ICBs, the voluntary sector, but also patients themselves. There will be patient involvement, public involvement in the prioritisation board, but there's a lot more to it than just having people on the board. So trying to strengthen the voice of lay people, patients, the voluntary sector is also really important. So there's a sense that people's views, people feel that their views can influence what NICE decides to prioritise and focus on, I guess, is what we're trying to achieve. So that's kind of one of the big things that's been going on over the summer. Again, happy to take questions on that at the end, but also the regional networks as well. There's a couple of other slides that I'm going to cover as well, if that's okay. I think I've got another 3 slides. So next slide, please, on different topics. I mentioned useful and usable. I mentioned digital living guidelines, and it's proving quite tricky. This is the idea of trying to bring our guidance together, different types of guidance into one offering for people such as yourselves, and more particularly for patients, and how you access that as well. This is what you might describe as a baby step, but hopefully is still useful, is trying to embed our technology appraisals, which I think most people will know here are essentially our guidance on drug technologies, not exclusively, but mainly is a shorthand way of looking at it, into our clinical guidelines, which are obviously looking at whole kind of areas and pathways of care. It's more difficult than you might think, than just sticking a reference in. And at the moment, we've done that on 3 pieces of guidance, taken the technology appraisal guidance that relates to obesity, relates to atrial fibrillation, and relates to pancreatic cancer. And some of you may have spotted I've talked about trying to bring things together into a more coherent package, and there are 3 very different pieces of guidance that we've decided to do that. The reason for that is, if I'm honest with you, is pragmatism, because they are kind of they're different areas, but they've been relatively easy to do. And it's a simple incorporation essentially, but the intention is to become more sophisticated on that, and there'll be more on that probably next time about what we're looking to how we're looking to tackle that. I can see a question from Diane there. I'll come to that in a moment, Diane. I'll just finish up on these last couple of comments. A couple of slides. Next slide, please. Continuing the similar theme of trying to bring things together, we've just launched, it should be on the text underneath, a web page for virtual wards. I don't know if anybody here is involved in virtual wards and trying to get a sense of how effective they are and what some of the benefits and potential risks are. There's 2 pieces of NICE guidance which we've tried to bring together, really focusing on acute respiratory infection. One of them is the clinical guideline on initial assessment and management, and that for the first time has got recommendations on remote assessment, and when people might be supported with home-based care or on a virtual ward. But there's also NICE guidance on virtual ward platform technologies for the first time. We know that this is a real growth area, and NHS England are really involved in this. So we're trying to assess some of the technologies that are being used. We looked at 13 different types of platform, 11 of which are currently in use. And we've made recommendations about their use within the virtual ward environment, along with recommendations, particularly for companies, about continuing to collect evidence on them. and it's the company's responsibility, if any organisation is working with them, to make sure that evidence collecting framework is in place. And so again, it's another example of where we're trying to bring different pieces of guidance together to address a particular topic rather than having separate pieces of guidance coming out. Next slide, please. I'm just going to finish off drawing people's attention to some of the recent guidance. I've kind of picked these out that may be of particular interest to you. The acute respiratory infection I've just referred to. You may well be aware of these already. If you move to the last slide, please. Glitch on my end. It seems to go. There we go. It's just moved. Just drawing people's attention to the stroke rehab in adults, whether this is a piece of guidance that may land with some potential controversy and something you may be involved in from a QI point of view. It's an update on the existing guidance. What's different about it is it increases quite substantially the recommendations for the amount of therapy and rehab that stroke patients should receive. And we've already had some pushback that it's unrealistic. And this is a great example of the situation, I think, where we find ourselves at the moment as a health and care system. The evidence is fairly strong that if we can increase the amount of therapy and rehab that patients get, and particularly immediately post-stroke, the benefits are pretty significant in the outcomes. We know that our outcomes compared to what's going on in other countries are poor or poorer. We know that if we can achieve this, there are benefits to the system in terms of savings. I can't quite remember the first year cost of a stroke on average, but in the second year, the average cost of a stroke to the system is about £28,000 a year. It's significantly more in the first year. There are savings to be made there that could be better used elsewhere, so we can deliver better care. But obviously, you've got that kind of, how do you get that resource? How do you find the therapists in the here and now to actually begin to develop that? So it'll be interesting to see how that plays out. So be aware of that particular one. I think at the very least, I think the guideline is really helpful because it guards against the potential to drift into expediency, which is, this is what we can provide at the moment and this is all that we can do. I think at the very least, this highlights, this is the evidence about where we as a country should be trying to get to, and let's not lose sight of that. And whilst we may not be able to do that now, we should be looking to work towards that. So that, to me, is a really important guideline. I've highlighted the two below for two reasons, because they come under this health technology evaluation, and I feel like I'm slightly talking to you with a kind of forked tongue because I've been speaking to you about trying to bring stuff together. And here is a new type of guidance, health HTEs, which I mentioned back in my last presentation. This is about stuff that looks promising, stuff that looks like it's got an evidence base, but it's a very immature market. The technology is not as mature as it should be. There needs to be more evidence to make what looks promising, give it a sounder evidence base. But you'll see there, apart from the virtual ward platform technology, the one above it is virtual reality. So again, it just gives you a sense of where we're all going. And this is on agoraphobia and agoraphobic avoidance early value assessment. So it just gives you a sense of how technology is going to really disrupt what we do more and more. Feed AI into that, and it'll be another key step as well. So I'm going to stop there. There's a couple of questions in the chat. I don't know whether you want me to go to them, Vicky, or there's any questions.
That would be great. That'd be great, Chris, if we can tackle those first. So Di talked, didn't she? She said it's a great move, this new framework, obviously. baseline assessment tool, I think obviously has got lots of statements in that frustrate staff. So I think it's yeah. Will there be any changes around that assurance side, or?
Yeah, hi Diane, good to see you.
And you? Yeah, I was just gonna, we've had baseline assessments for over 20 years now. And I just think they need to become a bit slicker, and they need to be more pertinent to the standards that we're looking at, because I know we've got the high level standard, and Amat's working with you guys at the moment to try and get all the standards on there. But when it comes to looking at the baseline assessments with the clinicians, it's just so frustrating because they just lose the will to live, basically. And I know that you can merge them and everything, but that's still a lot of time taken out of your work day to try and do all that, and then go and sit with the clinician as well to get that assessment. And I just wanted to know, moving forward with all the AI technology and everything, are we going to see something dynamic from NICE for providing assurance?
Yeah, I agree, Diane. I think the days of the Excel spreadsheet, etc., like that, are perhaps a little bit limited, and we need to kind of do something a bit different. There's quite a few changes going on internally within NICE, which I won't bore people with at the moment, but we've already updated, are about to update or finish updating the resource impact template, which is looking at the kind of financial impact of NICE guidance. And I think next in line next year will be to do something with the BATs, or whatever they will be called in the future. I don't know what that will be at the moment, but I think there is a recognition of that they do need updating. If we're doing all this, it's a bit of an old style tool. So
yeah,
sounds a bit waffly, I know, but watch this space, I guess, is what I'm saying.
That's good. That's good. At least you're considering it. Just while I'm on as well, I did put another question in there, and I just want to pull my hair out with HTEs because I don't know what I'm doing, and I think I need a dummy's guide to kind of navigate it and know what we have to do with the guidance and what assurance is requested, because to me it feels like it's a bit of an IPG where you have to, when you've got your new interventional procedures and you have to do your governance and your audit around it, it just feels a bit like that to me, but it's kind of already been approved by NICE, so it just blows my mind. I don't know what I'm doing. Yeah,
it's a bit I mean, I'll ask, it might be helpful to have a chat with Joe McCormack in West Midlands, but in the here and now I can send some links through. What I would say is it is they're quite difficult pieces of guidance to do for NICE. I think 2 or 3 things are happening. One, we're getting a lot of people saying we're using product X. Is it evidence-based? And nobody knows. And the market itself is very chaotic, the medtech market, with a lot of small scale, if you like, penetration into the NHS, people rocking up, big companies, but also you like Dragon's Den approach with stuff appearing. That is, and what you might call, this is a bit kind of exaggerating to try and make the point, really, what you might call shiny kit syndrome, where you've got products being produced by a company because they've got the product. So what we're trying to do is set a number of things with the evidence framework for companies, try and set expectations about what the service needs with NHS England and others. And then we're trying to set a framework where these new immature technologies get a first look before they find their way into the system. And then the second stage is to try to pin down the evidence a little bit more rigorously, which is where these evidence frameworks come in. And it should be the company that produced the evidence about the evidence framework and help make sure that evidence framework is in place. And it's the responsibility for the ICB or the trust or whoever to make sure they're not just buying off the shelf and using it. And I realise that is quite complicated because it's a kind of complicated issue. So it might be worthwhile. We could do, if people are interested, speaking on behalf of some of my colleagues, we could do some kind of short 10-minute, 15-minute sessions on HTEs if you want.
Yeah.
So I'll speak to my colleagues in the team and and if there's an interest in that, we'll try and see if we can put something on either here or regionally, whatever you think would work best.
I think that'd be really good, and it would be good if you could do like a working example, so we've got the guidance for what it is that we do with it.
Yeah, it's.
I don't know if anyone else feels the same. I don't know if it's just me.
They do die. They do die. So this has been raised by others in the network. I think I emailed you, Chris, about the HTE.
Yeah.
What was the specific expectation for us back in those provider organisations when these are published? What we expect, you know, because we want to do the right thing, don't we, by our patients? But it's just knowing how to take it.
Yeah, I mean, in I guess the time we've got now, there's no expectation like TAs that you will implement them, so to speak. But I guess what we're trying to draw people's attention to is we think this has got promise. We think you should consider, you know, you could consider using this technology, and that it would, on balance at the moment, it would deliver benefits to patients and benefits resource-wise as well. But the evidence is not crystal clear. Therefore, we need to collect more evidence, which is where these evidence frameworks come in. So it might be we could do a kind of like a 3 or 4 stage kind of summary, if you like, that might guide and might make bring a little bit of clarity, and perhaps follow that up with some short sessions if there's an interest in that. And I take your point about an example. A story tells a lot, doesn't it?
Yeah.
It does, and I think if we go back to all our nice implementation policies in our own organisations, we've also got to find a way of applying the right governance around introducing these things, which is what you'll say in DI, isn't it? Yeah. So it's just that little bit of national direction so that we're all doing it in the right way back in our own organisations, because this is about whatever we introduce, it's got to be done safely, it's got to be done effectively so that we reduce any avoidable harm. That's the main aim with innovation. Helen Way from Oxley's popped in that she's working with her knowledge and research team with these HTEs as well, just to make sure she's having those local discussions so that they're factoring in what they need to take forward. And Sarah Byrne obviously said the same about her innovation team as well. But Chris, I think nationally would be fantastic, because I almost feel like you could probably put more on if you run them nationally, because you're almost delivering it for everybody rather than working around the regions. And you could do a series of them, couldn't you? Which would be great. You know, in terms of NHS supply chain and things, because I'm just thinking about the technologies that get onto the mandated medtech list. Obviously, NHS England are working closely to make sure those are available on NHS supply chain. It just makes us easier for introducing those in our organisations. Around some of these other technologies then, is there any way of working with NHS England to get those made available, so we've not just got organisations going off on a whim to almost procure anything?
We do work with them to get in terms of supporting selection of nice medtech guidance onto the mandate. I mean, at the risk of I'm speculating slightly because obviously I don't work for an HSE. I think they're wary of putting too many things on the mandate. It's this balance. Do they force people to buy things and that gets the one side once for all, and that's great, or does it, you know, this is just unrealistic and things don't happen? So I think they're kind of it's a never ending, I suppose, kind of balance between the local and the national, but how much lead you provide. But we do have those links with them, and we do discuss quite a lot about because they've set a lot of the expectations about HTEs, for example, that encouraging NICE to get into this space. It's very much driven by the department and driven by National Life Sciences strategy, really, that NICE has got into this area because it's so difficult. And medtech, whether there's an evidence base or whether it's these HTEs, introducing them is often a lot more disruptive than drug technology or even a new clinical guideline, and so it does. Implementation is more challenging, I think. Yeah. So I'll have a chat with my colleagues with a view to maybe next time having a focus on HTEs for maybe this session.
Yeah, that would be brilliant. That would be great. Thanks, Chris. That's really good. I've got a question about the stroke rehab then, because obviously I totally agree with you. You've got to have the aspirational up there for us all to still be aiming to, regardless of resource, haven't we? I'm just thinking about what influence NICE have got over our commissioners, because some of this will be about increasing the commissioning behind the therapy services, won't it? And I know some of that's for our local discussions locally with our ICBs, and I know you've produced the guidance, but is there any influence there at all?
I think the one of the things that will be happening next year is there will probably be focus on particular kind of topic areas. So cardiovascular strikes me, although it's not my decision, but I think that's probably likely to be in its broader sense one of them, including stroke. And so in that sense, there'll be more of a focus on less areas. So we would hope to influence ICBs. I guess more realistically, the effort the NICE will have is trying to influence NHSE. And again, we do meet with them, but be perhaps a little bit more strategic, looking ahead with the prioritisation board about trying to get more oomph, if you will, behind NHSE and also CQC as well from the other side of things as well. So I think it's trying to move to be. We've always been very much trying to encourage and support and enable people, but I guess it's also trying to be get a little bit more push, perhaps, as well as support, and trying to find the balance. And I think that's what would be happening over the next year or two.
Yeah, brilliant. Thank you. Okay, so have we got any more questions for Chris? Have I missed anything in the chat, Marina?
No, you picked up the most recent ones with Helen, and Sarah Bernard said similarly that they've got an innovation team that they're collaborating with as well. So no, I'm not seeing any questions that come in the chat. Obviously, folks, put your hand up now.
Oh, sorry, I've accidentally raised my own. Sorry, I was meant to click on people. Yeah, we're not seeing any hands at the moment. Chris, that was really good. It's so good to get the latest update, make sure we're not missing anything, and then obviously to have that direct opportunity to ask you questions directly as well whilst we've got you in our virtual room. Obviously, we're really valuing the NICE reps are still attending those regional networks, which is what the members wanted and the NICE regional reps wanted as well. So we've got that more local dialogue going, because it's good to receive the information nationally, but obviously you'll have those more challenging discussions in those regional networks around what they're struggling with locally, which is brilliant to have the reps there as well. So yeah, that was really useful. So not seeing any hands at all. So I think that's that's okay from the NICE perspective. Okay. So Marina, I think we're over to Q&A generally.
We've not got any unanswered questions for the other speakers that have come into the chat. But if anybody's thought of any questions or any points that you'd like to raise about any of the things you've heard today, please do put your hand up or ask. Oh, we've got Chris.
Yeah, I was just going to say I'll take my leave if I may. I've got another meeting to go to, and also to say that this will be my last one. So I'll be leaving NICE in the new year. So I will speak to. I think you know Joe, do you, Vicky?
Yes, Joe McCormack. Yeah.
I'll speak to Joe about who's going to. I think it probably will be her taking over, but I'm not entirely sure. So it'll be somebody else next time. So thank you so much for having me and making me feel so welcome over these last couple of years. Thank you very much indeed.
Oh, thanks, Chris. Thanks so much for your input as well, and wish you the best of luck.
Thank you then. Bye bye.
Thank you. Right then, so sorry, Marina.
I was just going to say, if anybody has any questions, any thoughts that you'd like to raise before we close out the meeting, anything that's come to you while others have been talking, then please do raise them on there. I was just going to pop into the chat just a couple of bits that I was looking at as well. So firstly, I'm going to pop in the chat the link to the post on the forum where I've talked about the record keeping audit webinar. So just another little plug for that, so that you've got the link there. The poster is on this area of the forum, as well as the link to get directly into the meeting, so that is on there. And then a couple of people were also talking early on in the meeting about e-learning for clinical audit. Just to flag up that there are e-learning for health. There is an e-learning for health module on research and audit, which you can also get into through ESR as well. So that does also automatically go onto your ESR. So again, I've just popped the link into the chat there as well. Not to say that it couldn't be improved, or that we, that there's potentially further work that could be done to get better and more e-learning resources onto ESR, but at least there is something there for you. And obviously we earlier linked the HQIP e-learning as well. Yep, so that was just little bits as well, just to pop in there. I think that is all the bits I was going to put in. Yeah,
lovely.
But I'm not seeing any hands go up.
That education and training is a big thing still. We know we've got that gap in terms of our facilitators and things, but it is, having it linked to that ESR record. So I know that Danny Keenan was having some chats with Richard Arnold about education and training, so I know that there is some discussions going on, so we'll just see if we can find out a little bit more and keep everybody updated. So yeah.
And final plug, if people do want to come forward, obviously we've got for the NQICAN comms lead role. Save me trying to tossing about all over the place in the meetings, and also that support for your regional networks as well. Obviously, many hands make light work, so it's all very much appreciated, no matter what you can offer.
Yeah, you've done a fantastic job, Marina. You've been letting people in, you've been sharing slides, you've been on the chat, thank you. That's been excellent. Probably just quickly, whilst we've got you before you start leaving as well, is just if you want to see things put onto this agenda as well for the quarterly meetings, let us know. I know we've had a leader today, which was really good, wasn't it? Having that latest information fed back directly, and we'll obviously take some of that into the regional networks. I know we've got NRAP might be coming, the National Respiratory Audit Programme may come and deliver a similar session, so obviously we can be inviting people along. But if there's any particular ones that you think take more priority, or anything else you want to see on this agenda, just get in contact with Marina or I, and we'll help to shape the agendas with you. And then obviously you can feedback through your regional meetings as well, and through your regional chairs too. Yep, PSurf, yep, we've got that one as well.
We've
noted that, haven't we? So yeah. Brilliant. Otherwise, it's lovely to see you all. Last meeting pre-Christmas. I know you'll have some of your regional network meetings still in December before you break, but it's just a good opportunity to wish you all a nice, relaxing break. Hopefully you have got some time off over the festive period, and we'll pick up speed again in the new year. But yeah, lovely to see you. I don't know if we've got any of our regional network chairs on that want to say anything before we close at all. No pressure. I know that we've got a few of you on the call. Otherwise, I think I think we've gained back about 8 minutes. So hopefully you'll the rest of your day will be nice and smooth, and December will be okay, and you'll have a good festive break and new year, and we'll see you in 2024.
Thank you.
Take care, all. Bye-bye.
Thank you.
Bye.
Bye.
Bye. Thank you.
Thanks. Bye.